I'm the last person keeping you from going home and spending time with your family. I hope you think it's worth it. This is a little bit different talk, if you will indulge me, a different approach. I'm going to try to get you to think about changing everything you do right now. Beginning again, innovation. One of the things, I do multimodality, as likely most of you have had experience doing more than one modality. And the nuclear medicine physicians in the world do this, in the room, do this all the time. You switch disease states all over the place, so you think differently. And sometimes when we're in a given modality, we think very narrow-mindedly. And so I'm going to try to get us to think very broadly about disease, pathology, overlapping, what we can bring from one disease state to the other, one imaging modality to the other, understanding what is underlying diseases, and things like that. And so I've done a lot of work in nuclear as well as in CT, and I find that balance between the two and understanding anatomy and physiology, not just so focused on physiology, what is going on and under that. And I'm going to talk a little bit more about that, which we haven't had that much focus on CT. So they asked me to speak. This is kind of a strange title, don't you think? And so they asked me to speak about it. This was my talk, or the title of my talk at the Varani lecture at ASNIC last year. And it is published. If I can get this to move, I'll just do it this way. Oops. Sorry. So it's just published in June in JNC. So you can read about it, or you can email me, and I'll send the slides if it's at all helpful to you. So here's my career. So I don't know what it says about my career, but I can put all my career on one slide. So I'm going to show you 20 plus years of my life. So nuclear cardiology has been the test of choice for stable ischemic heart disease for many decades. Over the last 20 years, we have developed lots of evidence, particularly around risk stratification, stable ischemic heart disease, known coronary disease, revascularization, men, women, racial and ethnic subgroups, population subgroups. We've shown it to be effective, diabetics, the elderly, obese, etc. A lot of data on risk stratification. And we've developed, interestingly enough, very, very large cohorts, much larger than in any other modality. You look at the papers with MR or with echo, they're often quite small. And there's a lot of variability in your interpretation when you have a 30-patient study versus when you have 5,000. So one of the things that I have worked on is getting very large samples of patients so we can look at prognosis and make much more definitive statements about prognosis. And we actually tried to use that to employ this in terms of therapeutic decision making. You've seen this a couple of times, all these slides you've seen, so I'm going to go through them a little bit quickly. But this is evolutionary thought. Here we just evolved over 10 years of my career. We started doing clinical trials. Here's the COURAGE trial, which was a trial that was sponsored by our Veterans Administration, and it was published, this was published now a decade ago, where we looked at whether or not you could reduce ischemia with medical therapy versus revascularization. A landmark study, I hate to toot my own horn, but it was a collaborative effort across many, many authors. There was about 25 or 26 authors. So it was a group effort, and I think it had dramatic implications because that trial was negative. This was not. It was extremely positive message on the value of imaging, on the value of nuclear cardiology in terms of reducing ischemia. We validated that in the Berry 2D trial. Now, I don't think anybody has mentioned the Berry 2D trial. It's the exact same trial as courage, but in type 2 diabetics. So another NIH trial, and here is the paper that was published in Journal of Nuclear Cardiology, where myself and Amy Iskandrian were lead authors on this. We showed the exact same result in a larger sample of patients with stable ischemic heart disease, showing that revascularization at 1 year following revascularization, those patients had a marked reduction in ischemia as compared to medical therapy. So not necessarily an improvement in outcome, but an improvement in reduction in ischemia. We went on to look at much larger samples with PET. I don't think anybody showed data from the PET prognosis registry. This was another registry that I had led, and this was just one of the papers. We've had, I think, around 10 papers from this registry looking at prognosis across multiple centers, showing the exact same results as we showed with SPECT, but importantly, with PET. There was an important limitation in the evidence with PET. And we've now embarked on lots of investigations around flow reserve. And I'm going to talk about that in a minute, so I'm not going to really mention this too much. And then finally, the last 8 years of my life have been on the ischemia trial. Everybody sees the end product when I present the data in a year or so, but it's 8 years of my life prior to that. And honestly, it's 8 painful years, because it's organizing data from over 300 hospitals and getting all of that imaging studies transmitted, interpreted by a core lab. It's a lot of painful work, people calling me at all hours of the night, so I'm looking forward to finishing it. So you've seen this, and I'm not really going to go through it, but now you see just my whole career, all in one. And you can see iteratively how each step led to the next. One step just led that evidence that we had, led to the next step, led to the next step, led to the next step. It's kind of what you all did in training, right? It's the same thing. A research evidence builds on each other. Otherwise, you repeat the same mistakes of other people. So it's important to think about how we build evidence and what has happened in nuclear cardiology. So we started off very rudimentary. I remember when I was in training, these were just simple diagnostic accuracy studies. We had to identify one piece. We started to put together more pieces of this puzzle and understanding patient risk. There's a widespread validation of the findings on prognosis across the world, in South America, in China, in Japan, particularly with J-Access, large registry from over 100 Japanese hospitals, widespread validation, more pieces to the puzzle, putting together a complex puzzle, and then putting together clinical trial evidence. My opinion, all of this contributed greatly to what we've seen in terms of declining cardiovascular mortality. Okay, but now every modality, once it gets established, once it becomes conventional, comes to a point where some of the data doesn't look so good. And we are now a very well-established modality, and we've seen recent data that shows that we need to pay a little bit more attention to detail and start to think about innovation and ferreting out additional messages, clinical messages, which can help you, me, and all of our colleagues. So we've seen now what's happened in many places. We're start to test, we had an example, a case of a lower risk patient. We're starting to test patients with a very low coronary disease prevalence. It is for a variety of reasons, including the fact that many of these patients are being treated. We don't have natural history anymore, hopefully. They get statins, they get hypertensive therapies, all of which is reducing the prevalence of atherosclerosis. And so now the populations we see have a low disease prevalence. So we have to start thinking a little differently about how we test low disease prevalence populations. What happens when you test lower risk patients? This is not brain surgery. We see a declining incidence of ischemia, a declining incidence of abnormalities on perfusion imaging. We also see papers like this very large Clarify registry. You may not have read it because it went to a general medicine, which is really not good, right? Negative evidence going to general medicine physicians does not help us, but it went to a general medicine audience, And you can see 32,000 patients where ischemia was not predictive of outcome. Okay? Well, you know, there are a lot of reasons for that. One of them, which I just said, is we don't have the natural history of disease anymore. Somebody has ischemia, we treat it. We put them on anti-ischemics. So some of this is not unexpected, or it's what you would expect. But it's important to realize that this message is one that we see in the literature. We have negative trials. I shared that with you yesterday, the women's trial. And what we see when we go to the cath lab is that many times the patients don't have obstructive coronary disease. This is from a very large American College of Cardiology registry looking at referrals from stress testing to a diagnostic coronary angiogram. Only 40% of the patients who had ischemia on a stress test had obstructive disease. 59% did not. And this is almost in 380,000 patients. This is a strong statement about the need for alternative approaches for this and not sending people to the cath lab. Because even in these cases, you still have about a 3-4% procedural complication. The worst thing in the world for all the interventionalists, that all of your interventionalist colleagues, have a patient with normal coronaries that has a stroke, that has some kind of procedural complication. That's the worst feeling that they convey to me. And I think this is where we have to start thinking about, we need to do something else. We've also seen other modalities that have come up with perfusion imaging, have come up with ischemia testing. Here you see data this is from Marcus Chen from the NIH, the Core 320 study. He looked at MR and looked at the combination of, CT perfusion with CT angiography, compared prognosis with nuclear imaging versus prognosis with CT perfusion. Very large multi-center cohort published in Radiology a few months ago, showing equivalent risk stratification now with CT perfusion imaging versus SPECT perfusion imaging. So now we see competition. Now, trust me, I don't think CT perfusion has a huge future. It adds a lot of radiation. It's not by no means standardized. But this is just a message that there are other people trying to do what we've been doing for a couple of decades. And also looking at fractional flow reserve with CT. This has no future too, just as an FYI, in my opinion. I've written editorials about it. I don't have any relationship with this company. And it's in the United States, that's a $1,500 add-on procedure. It's very expensive. And I think it's going to hurt. And this is a statement that I worked on. I chaired the cardiovascular imaging committee for the American Heart Association, ended in 2017. We came up with this quality statement, which we published in Circulation Imaging just this past year. And it really emulates a lot of my thoughts about how you define quality with imaging. And of course, we do have this hierarchy of evidence. And as you saw in my career, I've tried to get as close to the tip as possible in having very high quality evidence so that you could actually employ this evidence. And we do have a lot of comparative, we do have a lot of randomized trials, and we have a lot of multi-center registries, et cetera. But you know, one of the things you have to think about is we do have abundant evidence, but is it enough? Is it contemporary? We see a lot of slides over the last few days from the late 90s. Clinical practice has changed a lot since then. So do we need to start to reinvigorate and get more evidence that's contemporary in contemporary populations, in diverse populations, from Colombia, Argentina, Brazil, all over the world. So we need to have this evidence. One of the ways I like to think about this, and this maybe shows you a little bit how strange I think, is how people look at healthcare. Here's life expectancy across a lot of different countries and how much on average that is spent on healthcare. So ideally what you want to do is spend a little bit of money and get a very high life expectancy. I think Costa Rica has, last time I checked, had the highest life expectancy in the world. And so they're probably way up here. You all can tell me where Colombia is on this. I couldn't find it on this slide. But here's the United States. Not so good. So so this would be considered a value added. Didn't spend so much, got a lot in terms of life expectancy. But what about this line? Covers out expanding inefficiencies. We've added on and added on and added on and only made a minor improvement in our life expectancy of our patients. Not necessarily a good way to spend your money. So it's like paying $1 million for a Volkswagen. Not so smart, right? And we did that without the United States has a life expectancy which is 3 years less than most westernized countries. So, not such a great job of what we're doing in healthcare. So I think in imaging, I like to think of imaging as a solution, not a problem. Often imaging is the target of ways we can cut. Healthcare really needs innovation. All of you think creatively every day when you look at a scan. Take that same innovation to think about throughput, to think about lab approaches. We do have inconsistent quality, and some of that is just being human. Some days I'm sure you look back at a scan that you read a year ago and you say, what the heck was I thinking? But that's part of that is humanity and being a human being. But we do test too many people. We have widespread waste, or we could do a better job, I should say. In the United States, we have unsustainable growth in healthcare. And we do, all of you have seen this. Healthcare is inordinately complex. We have to unmask some of that complexity in order for us to achieve optimal care. So we need what's called, our technology folks call disruptive innovation, personalized care. We can do that very easily with nuclear cardiology. We need new care models, which put imaging at the core of treatment. We need to integrate delivery. We need to have intelligent care environments, not ones that are focused on reimbursement or payment, but ones that are focused on patient care. So in imaging, I think we should be thinking about revolutionizing care, needing imaging strategies, not just an imaging test. We are creating a strategy of care that not only starts with the index procedure, but initiates therapies, looks for repeat testing, and a whole strategy of care, and also developing quality programs, which you can actually guide across primary and specialty care to have them have a better understanding of how good you are. And of course, I think we need very timely and improved access. I think there are many patients that don't get to you that should, and that's the same in the United States. We test some of the wrong people, but we need to actually think about who we're not testing, because obviously cardiovascular disease has a high mortality. So thinking more about being patient-centered, I realize this is a little bit different. So how do we have to start to be much more strategic. We started with some novel idea like the amyloid and the sarcoid. That's extremely novel. Then we have to think about how it's going to be implemented in order to create efficiencies of care for those patients and effective care. How we can be a part of care coordination. Oftentimes in imaging, we create an imaging test or a procedure, but it doesn't fit into clinical care. We can't see how it fits. It may identify risk, but we can't see. So we have to start to think about all of these areas that we could have novel discovery, how we can actually improve care and actually create more patients that are alive without any untoward consequences than were before. A little bit different way. I'm going to give you just 2 more kind of weird slides, and then we'll get into some imaging strategies. I love this paper. I have actually gotten into the last 5 years of reading papers outside of cardiology. I know that's heresy, but I find I learned a lot. So this is from a pulmonary journal. It's called, what they call this, a network approach to chronic diseases. And you've seen this over the past few days. Mental stress has the brain, it has the heart, and a lot of other things involved. So there's a lot of overlap between both the genetics of many diseases, particularly chronic diseases, the biology of it, the clinical indications, and the environmental exposures. There's this overlap. It's like a layered cake that all intertwines. And you can actually see a lot of different diseases which impact, in this case, lung disease. But look at the covariating factors or the similar factors. hypertension, hyperlipidemia. These are all factors which are related, diabetes, they're related to chronic kidney disease, they're related to smoking. So how do we think about this? If we have so many factors which are so similar across most of our patient populations, whether they be hypertensive, whether they be smokers and have lung disease, they have an increased risk of cancer. We all know this, but how do you actually think about that in terms of imaging? I'm going to give you, I have other examples of this, but I'm going to give you an example with CT just because I want to get you thinking about other areas. So about 15% of mammograms have breast arterial calcification on them. It's not hugely prevalent, but it is prevalent. Here's an example of a mammogram, and here the white is all breast arterial calcification. Okay, so now we have coronary calcification. And here's your lung cancer screening CT. We can actually visualize coronary calcification as well as the lungs. And if we started off with just doing coronary calcium screening, you can see all that calcified plaque. The US, there's about 33 million patients which meet criteria for coronary calcification. If we wanted to expand, if you're concerned that the woman who has breast arterial calcification, if she can calcify her breast arteries, she's also likely to calcify her coronary arteries. So now we're thinking across disease states, and we're making this connection between radiology and cardiology, or between whoever she gets managed, maybe a gynecologist, et cetera. We're starting to make this connection, and there we've just added another 20 million patients to be studied. If we go into lung cancer screening, we can add another 7 million patients. You say, well, you know, you're increasing your volume, but you're also increasing the number of patients that you can help by initiating preventive care in this much broader group of patients. So you're expanding the reach, but appropriately expanding the reach, because you're picking up these patients. So if they don't read the coronary calcium when they do a lung cancer CT, and it's right there, we've missed an opportunity for prevention in that patient. If the radiologist interpreting the mammogram doesn't interpret breast arterial calcification, we've missed an opportunity to intervene on that woman largely at a younger age, and she's at risk for coronary disease. You're going to see her later, but wouldn't it be nice if we could intervene on her here when she has that first mammogram that shows arterial calcification? So if we think about now turning everything upside down and thinking so differently about imaging and the reach of imaging, we have to think about refining, redefining, and innovation, changing our paradigm. So here's our 2012 document on stable ischemic heart disease. I actually did this figure. I wrote these sections with the 3 other people. And this is an outdated evaluation algorithm. Needs to be changed. We talked about the low-risk population. So few people that you see have obstructive disease. We don't need to start thinking about so much about who goes to invasive angiography. And we have to redesign this paradigm. Well, there's an example of redesign. And I think innovation requires questioning everything. I'm giving you an example from the United Kingdom. They have an institute, it's like a health policy institute, that develops guidelines for their National Health Service called the NICE, National Institute for Health and Care Excellence. They had a guideline on stable chest pain where they criticized the pretest risk as being inaccurate in women, which it is, young men, non-white patients. All of our pretest risk scores are terrible. The exercise ECG has a lot of problems. A lot of patients nowadays can't exercise. We talked about that yesterday. And there have been several recent trials which have looked at whether you should do an anatomic test first, or a functionally, or a stress testing first. And what did they come up with? Wow, they came up with, this is pretty out there, I must say, when I first heard about it. So what they came up with is they totally eliminated the pretest risk score. They just said if the patient actually had either typical angina or atypical angina, period, their first test would be a CT angiogram. Eliminated the exercise ECG, did anatomy first. Now, you may not agree with this, but I think it's an example of questioning everything. I will tell you that there was only one imager on this document who wrote this. These were all largely generalists who came up with this document. So we'll see how it goes. We'll see how well they implement it. This is just an example of how we can actually create innovative approaches. Not necessarily right or wrong, but focusing on changing things up to try something different. Now, what about the trial evidence? We talked about this, and this is one of the trials that I talked about yesterday. PROMISE trial, no difference in outcome, largely enrolled nuclear. Look at the prevalence of obstructive disease. 78% had atypical chest pain. Death or MI rate, very, very low. The rate of obstructive disease is just really, really low in this population. So what would you think if you saw this? What would be your first inclination to think about? The first implication is there's just too low risk population. And a lot of these patients didn't need to be tested, period. So we have to start thinking about deferring testing, having you be the consultant to say, not right timing yet. That's gutsy, it's innovative, it would be hard to do, but we have to start thinking about that. And we have to start thinking about different approaches to this that may be selectively imaging. And what could we do that would give you some idea about who was at risk? Well, we could add a calcium score. It's easy to do. Even this is United States reimbursement for the large payer and the government payer. But one of the things I like, so it's not expensive, but one of the things I like about calcium scoring is it really adds anatomic data at not much of a cost, and it really gives you an idea of when you see your perfusion imaging abnormalities, what the underlying anatomy could be. And it can help to guide preventive management very successfully. So this is an example of coronary calcium scanning. You see a patient here with no coronary calcium, a little bit of calcium here, moderate amount of calcium. I actually think that's a fair amount of calcium. And look at that artery, just totally saturated in calcium. The common way of measuring it is an Agatston score. It looks at the area of the plaque by the density of the plaque. You can see that, look how bright this is. This is very dense plaque, but we can actually measure the density of that plaque. And there's some thought less dense plaque is more ischemic. That's just one insight into what we can learn from anatomy. But we can look at the location. If you saw a patient with a woman, maybe she was obese, large breasts, reduced perfusion, and she also had a big chunk of calcium in her LAD, you'd have much more certainty that she has coronary disease and that abnormality may be real and not breast artifact. The number of lesions, we can look at diffusivity of plaque. We can actually look at the number of vessels, the size of the lesion, and the density of the plaque, as we talked. That's in Hounsfield units, which is just a measure of density. And so we can start to think about developing these selective imaging strategies. And you could look at a low-risk population, and if you test them, it's going to lead to a negative trial. So we can start to think about going back to more selective imaging approaches. Maybe start with the exercise ECG like we used to. Start with a calcium scan. And if they're low risk, they don't cost very much. We can separate those out. And it's the abnormals that we can go on to selectively higher testing. Here's an example of a trial, which I don't know if you all have seen. It's called the Crescent trial, where they used calcium scoring first, and in the opposite arm, they just did stress testing. So what they did was, if the patient had a 0 calcium score, they did nothing after that. This is gutsy. I don't think I could have done this in my institution. And only the patients that had more than a 0 score, they had detectable calcium, did they go on to additional testing, and showed that a huge difference in outcome. But what's interesting is that people had a 0 calcium score, they had no events. No events. And you say, well, that's just that one trial, Leslie. In the PROMISE trial, in this paper from Matt Budoff published just recently, he looked at prognosis by coronary calcium. Did you know that if you look at this trial, if you ferret out these results, you can see risk stratification with functional testing and with calcium testing, but 84% of the events in the PROMISE trial occurred in patients that had calcium. If you want to know who's at risk, a calcium score is going to tell you. Is it perfect? No, nothing in medicine is perfect. But this is a strong motivator for us to eliminate those low-risk patients who may not need additional testing. What else can we add? I'm a huge fan of flow reserve. There were several beautiful, beautiful talks yesterday. And I think we are at the tip of understanding how we can employ it therapeutically. You've seen some of this data. I'm going to just tell you, risk stratifies very nicely, uniquely identifies women who may be at risk, women who have these markedly reduced coronary flow reserves are at higher risk, and they do so with a less of a burden of obstructive disease, suggesting that there may be coronary microvascular dysfunction involvement, which we may be picking up. Now, I'll tell you, I think extremely differently about ischemia and obstructive disease. I'm going to share with you in the next few slides. We have to think very creatively about the diverse mechanisms. We have this light switch, ischemia, coronary disease, ischemia, coronary disease. It's got to go away. I mean, this is fundamental to where we are. You could have epicardial coronary disease, vasospastic disease. All of this is going to demonstrate ischemia, dissection, and this is more of an acute coronary model. You could have coronary microvascular dysfunction, but this is not separate. The vast majority of people who have epicardial atherosclerosis will also demonstrate abnormalities in the coronary microvasculature. This slide was shown yesterday, but the bottom was cut off, and it's the most important part of this slide. These mechanisms can overlap. So we can't talk about a woman who has purely microvascular disease, because the vast majority of women who have chest pain have some form of plaque. If you look at the IVA studies, it's 90% of the women who have evidence of microvascular dysfunction also have evidence of atherosclerosis. Not obstructive disease, but atherosclerosis. And you say, I don't really understand why that matters, Leslie. It matters because we can treat these people if we know they have atherosclerosis. That's why that matters. And so I think that's the important part about understanding atherosclerosis. We used to think about the stenosis-ischemia relationship. If you had a sufficient amount of ischemia, had to be a high-grade stenosis, they need to go to the cath lab because they need to be revascularized. We got to stop thinking that way. About half of the patients that have a high-grade stenosis are going to have a non-ischemic lesion. Now, we used to call that not functionally significant, but guess what? They're still at risk. They're at high risk of progression. They're at high risk of developing new lesions, some of which may be progressive and ischemic. And so you have to realize that when you're looking purely at perfusion, there's disease there in a certain population that is not ischemic. So you're going to miss that. You have to understand that phenomenon. But also what we're seeing is that we have ischemia without a high-grade stenosis. And this is just one example. This is a review paper we wrote in JAMA Cardiology, that in this neighborhood of 30 to 50% stenosis, we can make these patients, about a third of them, 20 to 30%, will have real ischemia in a 30% stenosis. We don't know a lot about this, but this whole idea of false positive stuff has got to go away. This is real ischemia. This example is of patients that had ischemia on a stress test, and then they had an invasive fractional flow reserve. 30% stenosis, fractional flow reserve showing ischemia. 30% stenosis. Now all our thoughts about ischemia, obstructive disease, has got to be expanded to understand that you can have ischemia without a stenosis. And we've got to know why that is. Well, if you got to know why that is, you have to start thinking about the underlying plaque burden. And this is my transition in my research career about 5-8 years ago, because the prevalence of disease is quite low. So and when the prevalence of diseases are quite low, you have to start thinking about plaque as the instigator